Good afternoon.
Hey, Chris.
How are you?
I'm doing all right. I feel like I have some direction, which is helpful.
Oh, good, because I wanted to get an update because, as a doctor and a patient, it's always interesting to experience that, right? Being a patient as a doctor, and you
So
know,
much.
you know so much, and it and
Mhm.
it helps and it doesn't help. So catch us
Right.
up.
Yes. Okay. So when last we met, the information that we had was the lab work showing the very low ferritin and the borderline low hemoglobin hematocrits. And my primary care provider had said, hey, let's just be cautious and schedule you for a pelvic ultrasound. So I had that last week. And then yesterday I had my follow-up appointment with her. And I, of course, got a copy of the ultrasound report and I read through it and I was like, okay, looks pretty normal, fine. I've got a new fibroid, didn't really think anything of it. And then I show up at my appointment yesterday and my poor primary, this lovely nurse practitioner, when we had a student in, which is always fun too, she's like, how are you doing? Did you see the report? And I said, yeah, I saw the report. Looks pretty unexciting. She's like, no, it was exciting. I said, what do you mean? She said, 37 millimeters, which for normal human beings, that means that one of the measurements they took was for the thickness of the endometrial lining to try to figure out if there's something abnormal going on, which for a postmenopausal woman, you really don't want to have an overly thick lining. For a still cycling woman, it's less of a concern depending on where you are in your cycle, which is just a crapshoot to figure out when you're perimenopausal. What cracks me up is that I read through the report and I saw endometrial lining of 3.7, which anything under 4 is totally unexciting. So I just breezed on through and it was 3.7 centimeters. So I have a
Oh,
37 millimeter thick lining in my uterus, which is,
oh,
that's
yeah,
big. That's really
yeah,
big.
that's big. That's like that. That's a
Right. Yes,
thing. That's a thing.
it's a thing. So because there is such a dramatic lining, of course, we have to investigate this just to make sure that there's nothing going on. You want to rule out endometrial cancer, which is incredibly unlikely, or are there polyps that are causing everything, which is much more likely. So, and I will get back to the ferritin. This is where
No, this is the story, and this is
yes.
this is the story that women go through and patients go through, and that like, okay, we're doing this. Oh yeah,
Right.
new
No, we're going to take this
information.
little side path first. Yeah, so this is one of those cases where I feel almost guilty, but very privileged to be a provider because I had my appointment at 8:30 in the morning. I left at 9. By 9:30, my PCP had called me and said, okay, so I called Kathy, who's the lead OB-GYN in at the hospital here. She's on vacation, but she's going to be back tomorrow. And she said she would talk to her scheduler and get you in this week on Thursday or Friday, which are her surgery days, which I know would not happen to a
Right.
normal patient at all, because I'm not established with Kathy. And so I feel very blessed.
And if you're not a provider, being nice to your providers helps that path go along. Like
That is
I
very
have
true.
I have seen providers move that along because
Yeah.
they really like you,
Yeah, that is
which is one of the reasons why I'm just like, don't stay around with a provider that you're like kind of like,
Mhm.
unless you have no replacements. I mean, we can have
Right,
a whole discussion on who you keep and who you move on from.
right.
But when you have providers that like you, make sure that they know that you like them.
Yes. And also and ask for
Yeah,
things.
and
She
ask
said,
for things. Yeah.
she said, look, I'm really uncomfortable. I want to not, she didn't say I'm really uncomfortable, but she said, I want to refer you for GYN. Have you seen anybody locally? And I said, no. And so, we ran through who the providers were here in town. She's like, or we could send you to Skagit, which is the next closest, or down to UW in Seattle. And, of course, my first thought is, oh crap, you think it's serious enough for UW? But anyway, I was able to say, I would really, if it's possible, I would really like to see this lead provider here just because she's got so much experience. She's very practical. I trust her judgment. And she made it happen. So probably also helps. She's my neighbor. Anyway.
And these are the advantage of small towns as well.
Yes, that is also very, very, very true.
Right. Yeah. And so part of what I'm hearing in the discussion is like, do I just want to default to the gargantuan UW, which is always an option? And in small towns, there's a limited number of providers, and sometimes those are phenomenally good providers, and sometimes it is too big of a fish.
Yeah.
And you want to travel.
Yes.
But you don't have the information. Like, this could be totally normal within the normal weirdness of you. We don't know.
Right.
This could be a big fish. We don't know. Right. But imaging's, the next level. As a provider, you kind of know what needs to be done, and that if it's a good job or not.
Correct. And right. If it's spookier than this, then yes, we can up level. But for what needs to be done next, which is, and bless them for doing it all at once. So this means getting a hysteroscope, which is a tube in the uterus to take a look around. So scoping the uterus, a biopsy of the wall and the lining to make sure that it's not hyperproliferative in a scary way.
And what is hyperproliferative? Just because that's
like way too much growth, which we know there's way too much growth, but is it just because of the perimenopausal craziness, or is there something spooky going on? And they can figure that out with a biopsy, which is great.
Right. Yeah.
And if they find polyps, which are a common reason for such a big buildup, the provider will remove the polyps, and they're going to do a DNC, which is a dilation and curettage, which is where they scrape out the insides of the uterus. This is used as a surgical abortion procedure, but also very commonly for situations like this. And then last but not least, she's going to just cherry on top, pop in an IUD. Because Mirena, which is a synthetic progestin secreting Mirena, will help decrease the amount of bleeding in the future while I'm going through all of this.
Right.
So it's going to be very efficient. And apparently I get the good drugs for this because they told me I have to fast.
Oh.
So
that's always good. Fasting, taking a couple of days to have medical procedures done.
Great. Yeah.
And so that's
going to happen on Friday.
That's on Friday.
Okay. Information. Yeah.
That's a lot of information, and I just want to slow down for a minute because, like, I can hear some of my patients going, "What? Surgery?"
Right.
Like they're getting in there and they're scraping things.
I know.
Like, why would you let somebody do that? Right. And sometimes that sounds really scary, which for sure. And going back to like why do they want to do this? And they're doing two things. One, they're ruling out a lot of really scary things. And so what doctors do is like, what's the most common thing and what's the most scary thing? Right. And the great thing is they get to do it both at the same time, just like what you said, right? Like the most common is like, you are just a creator of really big polyps, and like, this is just your natural you. And because what I learned in gross anatomy is that bodies don't follow the template.
No, not at all.
Ever. So we could still be just in Alethea template, right? It's going to rule out all the scary stuff. And then it's actually providing a solution.
Yes.
Right? So you don't continue to bleed hard. Right. Which is why we got here, because you were bleeding hard and now you feel fatigued and crappy, and we would like to create your get your ferritin up so that you can hike your heart out this summer. Right.
And that was a very specific and very personal. So like, I think it never hurts to share a little personal with your providers. Because when I was talking to mine yesterday, I said, I'm scheduled to go hike mountains in 6 or 7 weeks. I would like to be able to do that. And so she shared that with the gynecologist, like, she's hiking mountains in 6 or 7 weeks. We got to get this fixed. And everybody can understand that. And obviously, this is not life-threatening. This could wait, but it's really wonderful to know that there are steps that can be taken to make this better sooner.
Yeah.
And then, so the other aspect was, I said, look, these levels, they're crappy. I would like an iron infusion. And my provider said, I don't know exactly how I can make that happen, but I'm pretty sure I can make that happen, because it's not common for primary care providers to order iron infusions. They would refer you to a hematologist who would then make the decision sometimes if they thought it was appropriate. But she said, I think I can make this happen. Let me see what I can do. So that would be really lovely to be able to do it right here in town, for obvious reasons, because just for your feedback, Chris, the group that you pointed me to in Seattle, which does sound lovely, and I was happy to see some of my, one of the founders of the clinic is somebody I went to school with. They're not accepting new patients.
Oh,
fall, they said.
Okay.
So they just had to put a temporary hold, and then they recommended, I'm blanking on his name, but there's a group in Edmonds that I can share with you that is taking new patients, and they were great. I talked to them. They were very competent. They were very welcoming. And they said, it's $265 a pop if you have to pay out of pocket, but if you have decent insurance, we can usually get insurance coverage for $40 copay. So I was all set to schedule that, but I wanted to hold off and wait to see if I could make it happen locally, just for logistical reasons.
Yeah.
And no timeline on that yet. I just called and left a message for the infusion center to see if they'd gotten the referral, to see if we can get that going.
Yeah. Nice. So for those of you who are like, this is the first information about infusions, just there's kind of a scaling of different things you can do for iron deficiency. Yes. You can do food, which is always important. You can do supplementation. And what I have found is that if people are as low as Alethea is, I'm like, let's just do an infusion. And because you feel better much faster, because it takes months to do food and supplements to get anywhere where people are like, oh, I have a little bounce in my step. Because it's just going from 5 to 50 is really hard. You can use infusions for that, but I wanted to get caught up. And what I hear is that you're still looking to make sure you have a good cause, because that's always really important. You also had to do some legwork to get treatment, because sometimes even as patients, we have to do legwork to get the treatment that we need, because our providers either don't have the resources, haven't done this before, don't know if people didn't know that you could even do it.
The impression I got was that my primary would have just defaulted to, we know that the safest thing to do is to just do supplementation as long as you're tolerating it. And so that would have been the default. So I think it was really important that I said, I would like to try an infusion, please. And she was like, okay, let's see what we can do to make that happen. But had I not stated it that clearly, then it probably, and had I not known to ask for that, it probably would not have come up until my hemoglobin and hematocrit were totally tanking. And it would be really nice to correct this before we get to that point.
Yeah. And there's this middle ground that sometimes happens with people, in that, like, because now you know that you have to be supplementing, like, it would be probably, you would never tank enough. Right. But like, I've had people who I supplemented for a year, and because of stress and food intolerances, and like, it just never got off of the bottom of the barrel. And I was just like, infusion, and they're like, magic. And there's always a little downside. We'll talk about that, but magic with a little bit of downside. So thank you so much for sharing that, your story, because it's an adventure. This is really real.
It
right?
is. And it's always, I always have to step back and remind myself that this makes me a better provider,
Yeah,
because it reminds me, because I feel vulnerable. I have to go and, you know, go deal with this medical procedure. It's probably not going to be terribly comfortable.
yeah,
But I know, at least intellectually, I understand this is going to yield benefit in short period of
yeah,
time
yeah,
of no longer losing as much blood,
yeah,
but it's still, and it's annoying, to say the
yeah,
least.
yeah,
So it's very easy for me as a provider to be a little bit cavalier, is too strong of a word, when I'm like, okay, we just need to do this and everything's going to get better, but it's still, whatever this is, it's still a
yeah,
big deal.
yeah. Can I ask you a couple of personal questions? And
Sure.
so, I've been with patients and I've been with friends who, like, the most common it comes up is they go for their mammogram, they're like, oh, there's something, we want to biopsy it.
Hmm.
Right. And then it takes a couple of weeks to get a biopsy. And then it
Right.
takes like 4 weeks to get the results. And they have to sit in that space of like,
Hmm.
what is this? What does
Right.
this mean for my life?
Yeah.
Like, what, like, so, I mean, you're kind of in that space as well. Like they're gonna do advanced diagnostics to make
Mhm.
sure that there's nothing there, right? Like,
Right.
so how is that sitting with you, and how are you sitting with that, right? Like, because
Right.
boy, sitting with patients who are going through that, like, it's an awkward, hard space to be in for,
It is. Yeah,
right?
it is. And this is my second time doing something like this, because I did a Cologuard test that came back positive. It was a false positive, and had to wait a couple weeks until I could get a colonoscopy that was fine, totally fine. So that was my first experience with, oh crap, do I have cancer?
Right.
Or similar. So at least this is a little bit less scary than that experience. And I remembered from that experience how important it is for me just to do things that are very grounding for myself, to spend time with people that are not stressful and dramatic, aside from, living with teenagers. But what are you going to do? Ask for extra hugs, and just be patient with myself and understand that it's okay to feel uncertain and vulnerable, and that I know about myself that I will feel like I already feel better today than I did yesterday, because the scheduler called me and now I have a path forward. The
Mhm.
hardest part is the uncertainty and the waiting. So I know that I will feel better. I'll get the procedure done. Not my favorite way to spend a Friday, but not the end of the world. And then it will be hard again, waiting for the results of the
Right.
procedure. But it's just, one day at a time, and this is part of life, and our bodies are amazing, but they're also kind of mechanical objects. And it's creepy to think about that,
Right.
but it's also true. And that helps me to understand that, you need to get the tune-ups, you need to get the things repaired sometimes, and that's okay. It doesn't mean that there's anything fundamentally wrong. You just need a little extra help.
Yeah. Yeah. And I think part of what you're pointing at is that when you're in the space, the Dan Siegel says, name it to tame it. And
Yes.
like if we keep it in front and be like, oh, for the next few weeks, I'm carrying this stone of
Right.
unknown, and I'm just going to keep that front and center. And for the people who are close to me, I'm just like, this is what's up.
Right.
This is what's up for me, right? Like, and so I might be a little emotionally off, or I might set a boundary and be like, oh, sorry, that's chaos I can't deal with right
Yep.
now. Why don't you find somebody else?
Yep.
Hopefully you have somebody else, right? Like, just setting those boundaries in that, because like, it's definitely something that is a very human experience, which is to sit in the unknown.
It is.
It is. And we probably practice it more and more each decade that we
I
are
think
alive.
so. Yes. Right. I'll whip out my, Dalai Lama book and start reading that before bed again, because it's just very soothing.
Right. 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 And for me, like, I know that in my life I have dealt with a lot of change, abrupt change in my life. And like, I've navigated that. And so, like, really, building that you have a structure and a community and a family that's going to help you navigate this regardless, right? Like, because that's what we do when we're alive.
Yes, I consider this also to be just a big practice for the bigger things that are inevitably ahead, because stuff happens to all of us. So it's the people I see in my practice, the people who have not had any trials with their health when they get into their elder years, and then all of a sudden it starts crashing down, which does not happen to everybody, but does to a few people. And they're the ones that are totally floundering, whereas people who have dealt with health challenges earlier, they're quite a bit more sanguine about that. Oh, well, okay, here we are.
Right.
Yeah.
So it will be. And I really appreciate you allowing us to go on the journey with you, because it's, as I said, it's a very human journey.
It is.
Nice.
Yeah.
Okay, well, that's our video for today. So,
all right.
Thanks, everybody. Well, you'll check out the next one, because we're just going to keep doing the series, and the whole journey will be completed before we publish this. So
definitely, no one will be left with a cliffhanger.